you can see that it outnumbers both of those problems. And with overactive bladder, a lot of people have a mentality that you kind of have to suffer in silence with this problem. And that's simply not true, because what happens is it really is an impact to your lifestyle. It can interrupt sleep. It can interrupt self-esteem and confidence, because it can disrupt your ability to participate in normal activities during the day and evenings. So it is something that many people think doesn't need to be addressed, but we really do have a huge prevalence of these problems. So what is normal, which is a common question that I'm asked. Normal would be less than 8 times to the bathroom during the day. And that's from the time you get up in the morning till the time you head to bed in the evenings. And then on the overnights, really not more than once or twice out of bed to visit the bathroom at most. The urgent feeling of I have to stop what I'm doing in order to get to the bathroom quickly enough to not have an accident, or planning your day around where you're going to be and where a bathroom might be available. We find that some people simply don't drink enough fluids because they don't want to make urine, as the fear of being in a position where there's not a bathroom available quickly enough. And then lastly, for people who are having urge incontinence or fecal incontinence, having to use pads to control that leakage and the stigma that can go along with that. So how does the bladder work? Well, there's a complex system. The center that controls your bladder obviously is in the brain, and it sends signals down the spine and signals the kidneys as to how they should function and how much urine they should be producing, as well as what the bladder should do when it senses fullness. So if there's a breakdown in that system, and you can see this demonstrates the same thing is true for the bowels as well as the bladder. It's one single nervous system at the level of the pelvis. And if the rectum fills with fecal material, what should happen? And if there's a breakdown in this system, there can be some incontinence issues. So what are the causes for incontinence? Well, obviously what your intake is has a direct impact on that. Medications that you take, frequently people will take diuretic medications, which are made to try to eliminate extra fluid in the body, and that's going to create urinary frequency and urgency. Reduced mobility, people who become deconditioned end up in short or long-term rehabilitation. That can have a direct effect. And then pregnancy and childbirth, both are disruptive to the pelvis and the pelvic floor muscles, as well as any pelvic floor injury, a traumatic injury, such as motor vehicle accident. And then lastly, radiation into the pelvis, both men and women, that can affect the overall ability to control bladder function and as well as bowel function.
All right, so once again, I'm Cara Breston. I'm one of the PAs at Pikes Peak Urology, which is a branch of Colorado Springs Urological Associates. Just want to say thank you for joining us tonight. We're so excited to have you. So I'll be talking about a few of these conditions, and there's really 3 urinary things that we'll talk about tonight, or conditions, and then also we'll talk about fecal incontinence. So I'll go into a little detail on these 4 conditions. So 3 urinary and then the fecal incontinence. So stress incontinence, we're not going to go into a lot of detail on stress incontinence tonight, but I do want you to know that there are different types of incontinence. So stress incontinence is one of the types of incontinence that we will treat. So stress incontinence is a leakage when you cough, laugh, sneeze with activity, exercise. I see a lot of women after childbirth will come in with stress incontinence, or men after prostate surgery. That's something we'll see pretty often. So stress incontinence is going to be treated an entirely different way from the incontinence that we would associate with overactive bladder. So I won't go into a lot of detail on the treatment tonight. If you do have any questions on it, you can always leave a question in the comment section, or I can definitely go into more detail over the phone with any of you if you have questions on that. So that's the main difference I wanted you to know on stress incontinence. I'll go into more on the urge incontinence as well. So the second urinary topic that we'll cover tonight is urinary retention. So you think retaining urine. So if your bladder is not fully emptying, that's what we mean by urinary retention. So there's kind of two ways to break it down, whether there's obstruction causing the retention or it's more bladder related. So with obstruction, we'll see a lot of men come in with large prostates that can make it difficult for bladder emptying, or strictures if there's scar tissue in the urethra. So that's treated by treating the obstruction. So with prostate, we do surgery, medication. If we're looking at the other side of urinary retention, which is more bladder related, so if the bladder is weak or bladder doesn't respond to nerve stimuli, then you're going to have a difficult time emptying your bladder as well. So that's more the urinary retention that responds to the Interstim treatment, which Dr. Walsh will talk about in more detail here later tonight. So with urinary retention, you might notice a sensation in the lower abdomen of not emptying. Some people, if it's been chronic, they won't even feel those urges to go even with a large amount of urine left over in the bladder. And some people will complain of a weaker kind of a dribbling stream. So this can often require use of a catheter. So that's one topic that, once again, more the bladder side is what we'll talk about in more detail. The third urinary condition that we're, the main focus of tonight really is overactive bladder. And Dr. Walsh already mentioned kind of the main factors of overactive bladder, which include frequency. So going to the bathroom often, urgency, really having to rush to the bathroom, and then incontinence. So this is different from that stress incontinence that I talked about earlier. So the urgent incontinence is really going to be if you can't make it to the bathroom in time. So this is more related to the bladder, where it squeezes and your body just can't get to the bathroom in time. You might not even have a full bladder when this happens. That's something that we'll see with overactive bladder. And really, you don't have to have all three of these things to be diagnosed with overactive bladder. But those are, some people will have all three, some people will just have one. But that's really the main focus of tonight. So once again, if you're going to the bathroom more than 8 times per day, or if you're having to wear a pad just because you can't get to the bathroom in time, those would be signs that you might have an overactive bladder. This is a little bit different from the three that we just talked about. So this is going to be the other end, so fecal incontinence. With fecal incontinence, I think of if you can't get to the bathroom in time, but the bowel side, so not the bladder. So a lot of people, if you struggle with this, you'll be rushing to the bathroom. You might not even feel the urge to go, and you might have some accidents, or some people just can't get there in time, kind of the same as the bladder. So this also responds to the Interstim treatment. There are some behavioral changes, diet-wise. There are some medications that can help, but really Interstim is a good option. So once again, Dr. Walsh will cover that. So the good news is these treatments, or there are treatments for these conditions. So once again, we'll really cover on the overactive bladder side of things, but urinary retention, fecal incontinence, those also can respond to some of the treatments we'll talk about tonight. Once again, stress incontinence, I know I covered that in a little detail. If you do have questions on that, just leave a question in the comment section. So anytime you're diagnosed with overactive bladder, I break it down into 3 different types of treatments. So there's lifestyle changes, medications, and then advanced therapies. So I'll talk about the first 2, and then Dr. Walsh will really get into the advanced therapies. And starting with the lifestyle changes. So there are some simple changes you can make, or behavioral modifications that can help manage some of your symptoms. So diet, healthy diet, exercise, those are important. Focusing a little more on the diet side. I always mention caffeine because that can be a culprit for some. Caffeine is a stimulant, so it can stimulate the bladder. And some people will notice that their symptoms worsen after their morning coffee. So an easy way that you can try to manage some of your symptoms is just cutting back on your caffeine intake, or spreading your caffeine intake a little more throughout the day instead of drinking 3 cups in the morning of coffee. So and a couple other things too. Dr. Walsh already mentioned, fluid restriction. Some people are doing this chronically, which obviously you want to make sure that you're hydrated. So this isn't something that is sustainable. I do always mention if you have a big flight coming up or a big road trip, you can watch your fluid intake more than you would on other days. That can help. Don't drink a big bottle of water before you have a big flight or anything, but it's not sustainable. So cutting back on your fluids really isn't a good long-term treatment. Otherwise, we will send people to pelvic floor physical therapy. They go through biofeedback with you, and they can teach you some exercises to control those urges when you do feel a strong urge to go. A little side note too, pelvic floor physical therapy is one of the treatment options for the stress incontinence. So there is some overlap, but usually those do require two different treatments, stress incontinence and urge incontinence. So if the behavioral modification that you try is not effective, or you're still not happy with where things are at, even after trying all those things, the next step would be to start an oral medication. So there's really two big classes of medications that we use to treat overactive bladder. The first class, anticholinergic class, has been around a long time. These medications are cheap, which is one of the pros, but there are a lot of cons to taking the medication. So some of the more common side effects include dry mouth, constipation, blurred vision. And with some of these medications, there's been some research that would show an increased risk of dementia for anyone that's taking them long term. So it's not something that I would use lightly by any means. And I really try to avoid these medications and anyone over the age of 55, if you're thinking long term. So oxybutynin is one of the more common, or ditropane would be the brain version, is one of the more common anticholinergics that people have heard of. The second class of medications, the beta-3 agonist class, has been around. They're newer, so they have fewer side effects, and so that's the benefit is that they have fewer side effects. Myrbetriq, Gemtesa are the two medications in that class. Myrbetriq, I will note, there's been studies that show that it can raise your blood pressure. So anyone that has high blood pressure, it's something that we do need to monitor. The other big issue that I have with Myrbetriq and Gemtesa is, since they're so new, they're often quite expensive. So your insurance doesn't always cover them. And even if your insurance does cover them, sometimes they're just not affordable. So, you can see even in the slide, about 72% of people stop taking their medications after, within 6 months, whether that be due to the side effects or the cost of medication. So those are the first two categories that we would use to treat overactive bladder. I'll pass it back over to Dr. Walsh, and he'll cover the third line therapy options.
I want to make sure that it's clear when we talk about urinary incontinence, there are two very different types of incontinence. As Cara said, there is stress incontinence, which basically is anything that pressurizes the bladder, like a cough or sneeze. And that is classically one of two types of surgical corrections. And then there's urge incontinence, which is really a change in the sensation in the bladder of fullness. And that can be a positional thing. Some people only have it when they're laying down in bed. Some people have it throughout the day and night. But that is classically what we're talking about right here, where it can begin with behavioral changes, lead to medications, which, as you can see at the bottom of the slide, there's a high dropout rate for a variety of causes, mostly side effects. And then we talk about the advanced therapies, which is referred to as neuromodulation. In addition to the neuromodulation, we also talk about Botox. We use Botox for a multitude of things throughout the body. It's been used for headaches and migraines for years, along with many other conditions. And we have found that it can be very effective when injected into the bladder. The downside to Botox is that it is very difficult to gauge exactly how much calmer the bladder is going to be. And so with a standard starting dose of Botox, there's about a 6% incidence of urinary retention where it will work too well. The bladder is too relaxed, and you can't empty the bladder at all without the use of a catheter until the effects of the Botox wears off. And that's kind of the second prong of the problem, is that Botox on average with a starting dose lasts about 6 months. So it's something that is repeated time and time again. Sometimes that can be done repeatedly in the office setting. Sometimes it requires a trip into the operating room. But as you can see, again, this is a therapy which has some downside to it and ultimately can end up with a fairly high patient dropout rate. So advanced therapy, and when I say that, I mean neuromodulation, as I just mentioned, can involve nerve stimulation. And we have a couple different ways that we do nerve stimulation for the bladder. For the bowel, we really only have one type of nerve stimulation. And so when I talk about the two types of nerve stimulation, one is a peripheral nerve stimulation, one is a more direct stimulation to the bowel or the bladder nerve. It's the same nerve. The posterior tibial nerve modulation, which is the MEDTRONIC NURO system, is, as you can see, a very small, it's almost like an acupuncture needle that's implanted into the nerve called the tibial nerve down by the ankle. And that nerve travels up the back of the leg and enters the pelvis and ultimately becomes the bladder nerve. And so by stimulating that nerve, which is completely painless, for 30 minutes, once a week, typically for 12 consecutive weeks, we can overcome a lot of the overactivity in the bladder and retrain that bladder nerve to behave a little bit more like it should. The one problem that we encounter is that we're trying to tell the bladder nerve what to do from 3 feet down the leg. And so there can be some loss of signal and some translation changes that happen along the course of that nerve. And the other thing is that when we transition after the 12 weekly sessions to a once a month kind of touch-up session, we find that some patients without the weekly stimulation, they kind of slide back to where they started as far as bladder control. And the durability is not as good as the weekly stimulation. And the reason for that transition is truly driven by the insurance companies. So the more direct or sacral nerve stimulation is a procedure where we directly stimulate the bladder nerve where it lives, and that is in your tailbone or in the sacral bone. That is both the bladder nerve and the bowel nerve. And so many times the gastroenterologist will see patients for their fecal incontinence, and historically, there hasn't been a lot of treatment options, and it's frustrating for both the physician and for the patients. And so ultimately, there are a few gastroenterologists who do some neuromodulation procedures, but a lot of times they refer the patients over to us just because we have been doing this for so much longer. Sacral nerve stimulation has been around since the early 1990s. So some of us who began all the way back then are approaching 30 years of experience with this technology. But this is a very small implantable electrical lead, which is put right where the nerve is in the sacral bone and left in place for several days, where it is constantly stimulating that nerve. And by constantly stimulating that nerve, we can gauge over the course of those several days exactly what will happen and how much improvement or difference the patient will notice. The best part about this technology is that about 5 years ago, the FDA approved an in-office test. Years ago, we used to have to go into the operating room simply to implant a test device, only to find out if it's going to work or not. Now, we have a much easier way to do this. We do a test in the office that's about 15 minutes. And as I said, it's laying down on your tummy. The worst part of the test is injecting a little Novocaine to numb up the skin right over the tailbone. And then put that little tiny wire lead in next to the nerve and stimulate the nerve. And we can usually tell as we do the placement of this test lead by the nerve, based on what questions that we ask of what are you feeling right now and where are you feeling it, we can tell how well it's going to work. Because what happens, the premise behind this is that this is creating a pelvic floor muscle contraction. And so typically you can feel that muscle contraction. It's not painful. It's just a kind of typical, most patients describe it as a tapping or a fluttery sensation. And that may be deep in the pelvis. It may be in the area of the bladder. It might be in the area of the vagina in women. And if we get that sensation, then we know that we're stimulating the proper nerve. And over the course of 3 to 4 days, we're really going to get an idea of exactly how much better things can be. So who's a candidate for this? Well, anybody who has symptoms of overactive bladder or fecal incontinence, or simply urinary retention where we have eliminated the possibility of an obstructive cause like a large prostate or any sort of anatomic problem in either men or women that may require catheterization or intermittent self-catheterization, or simply not emptying to completion and carrying a large residual in the bladder all the time. If you tried the simple things such as lifestyle changes, if you've been on oral medications and have had side effects and causing you to drop out, or didn't like the medication for another reason, or found that financially this was not feasible, then you're a candidate for at least a discussion and learning a little bit more about what we call our care pathway. And we like to see our patients complete the care pathway, and we find whatever option is going to work best for them. Everyone wants to know, well, what's the downside? What could go wrong? Is this safe? As you see, from a satisfaction standpoint, almost 85% of people notice a substantial improvement. I like to tell my patients that with sacral nerve stimulation, we have about an 80% chance of improving your symptoms by a minimum of 50%. You have to follow along. That doesn't mean it works perfectly, but we have a chance to significantly improve the problem. And sometimes even we will do some nerve stimulation and we may go back to medication and augment that nerve stimulation by adding back a medication that we had used previously, or possibly doing some pelvic floor physical therapy and biofeedback. It's not a treatment that is out there by itself. We very commonly will combine multitude of treatments to find what works best for certain patients. I like to think that all of our patients with fecal incontinence and with urge incontinence are very unique. There's not one pattern to this. Everybody has a little different story and requires a little different treatment. But if you compare it to some of the oral medications, it has much greater durability, and people do not drop out of the program. And classically, before this became a more widely recognized treatment and simple to do with office testing, people dropped off of medications, left the practices, never discussed it again with their primary docs, and simply felt that they were doomed to suffer in silence for the rest of their life. Because frankly, with a lot of our female patients that I see, they'll say, my mother had this, my grandmother had this, and this is just what my family does. And that's simply not the case in this day and age. So the goal is to not have life interrupted by your bladder. And we frequently hear people say, I no longer go out with friends, or I have to know exactly where I'm going to plan my route in order to find a bathroom, and I won't go somewhere new. Or traveling on airplanes or long car trips can be very troubling. And so, you don't have to have your life change because of your bladder. We want to change your bladder so your life doesn't change. So Cara and I are here. We would love to meet you. We would love to talk about any problems that you have, be it fecal incontinence, urge incontinence, urinary frequency, urinary urgency, getting up frequently at night to empty the bladder, not being able to empty the bladder and not due to obstructive causes. And we can help you figure that out if it's unclear. But we have 2 locations, and we would love to meet you at either one and get you into our care pathway. So I think maybe we'll open it up to questions.
That is awesome, Dr. Walsh and Cara. You guys did great. There are a few questions, so I'm just going to go straight into them. I'll let you answer, and then I'll move on to the next. So there is a patient that is, or I'm sorry, somebody watching that is asking, would this Interstim solution potentially interfere with an implanted stimulus masking device to block pain signals related to the SI joint pain?
No, it won't. That question comes up frequently about SI joint stimulators, as well as pain pumps for the spine. It's implanted in a little different spot. We have plenty of patients who have more than one stimulator, and there's no crossover. So it's safe to do with other implants.
And can you go back one more slide so that people can, there's somebody asking about the location.
Sure.
Perfect. Thank you so much. And then my next one here is asking, will my insurance cover the device and the surgery itself?
Most insurances will cover the testing. Certainly every insurance will cover the office visits and surgical implantation. We make sure to do all the prior authorization before any testing in the office or any implant surgery. So we know ahead of time that your insurance company has given us the green light to move forward.
You had mentioned that these are MRI compatible. Does that mean I can get an MRI of any part of my body, or just specific areas are safe?
Nope, that was a very big change in technology that's happened recently. Classically in the past, if you had this implant, you could not have an MRI from the neck down, which was quite impeding for a lot of people who had spine issues especially. But now all of our technology is MRI compatible. You can have an MRI of any part of your body without any interference.
I have another one here that says, I only have issues with an overactive bladder at night, so I never get a night of uninterrupted sleep. What are your recommendations?
Well, again, I said that frequently we'll find this is a positional issue. And so I do frequently hear people say it's either a daytime problem or a nighttime problem based on positioning. But, that's something that we would want to kind of start at the beginning, evaluate a little bit more, try and get a handle on what the cause for that might be, and perhaps start with some simple medication samples, give it a try, move on down the care pathway. And as I said, each step of the way, we kind of weigh the benefits as well as the risks before we do anything.
One thing I would add too, just a easy behavioral thing too. A lot of people, Colorado specifically is very dry. So I hear a lot of people drink water all throughout the night. So an easy thing you can do is just limit your fluid intake a few hours before bedtime. That can help a little bit. Obviously, it's not going to, completely cure the problem more often than not. But that is one thing I usually mention too, is just watching your fluid intake before bedtime. If you're really you're getting up multiple times at night or having more accidents at night.
Will this impact UTIs? I have an overactive bladder, but I also have frequent UTIs, even though I go to the bathroom many times a day and night.
It's very common to have a mixed picture with multiple diagnoses going on. Recurring UTIs, frequent UTIs, chronic UTIs, whatever phrase you might like to use, can kind of coexist with overactive bladder. Sometimes it's the cause for the overactive bladder, and sometimes it's not. So we work, hard to tease out what the real root of all your symptoms are. And this may be something that would be helpful for the overactive side of that equation, but it's not likely that's going to have any impact on reducing the frequency of the infections.
Is there a required process of elimination that I would have to take the drugs before I could jump directly into the Interstim process?
Typically, most insurers do require several kind of steps through the process. And that's why we've created the care pathway. We can make some simple, quick tests with medications or with any modifications that we do. And we can move along the pathway fairly quickly if our goal is really to get to the third line therapies.
There are nights I get up 1 to 2 times to urinate and times when I get up 5 to 7 times. Is this a situation that requires follow-up, and would the Interstim work?
It might possibly work quite well. I described all of the symptoms, the nighttime issues, the urgency, the frequency. These are bother issues. These aren't necessarily medically harmful issues. And each patient knows what their level of bother is and when they're bothered enough to take that next step. And if you're having more nights where it's 1 to 2 and there's an occasional night where it's multiple times, then maybe you haven't reached that point of crossover where it's time to do something. Perhaps that's the other way around, where most nights are bad nights and you're getting up multiple times. We can certainly talk about that. The neuromodulation is certainly in play as a treatment option as we kind of work through that.
Will the nerve stimulation work with nerve damage from prostate cryotherapy causing incontinence?
It can. I have a not insignificant number of patients who are previous prostate cancer therapy, be it radiation, cryotherapy, as well as surgery, who have some control issues with overactive bladder symptoms and primarily urge incontinence. If it is truly urge incontinence and it's not related to damage to the sphincter muscle in the urethra, which would ultimately result in stress incontinence, then yes, it can help. And trying to determine between those two causes, we have several things that we can do to try and sort that out.
Are UTIs related to frequent times of urine trips at night?
The common symptoms of UTIs are frequency, urgency, getting up more often at night, burning with urination, blood in the urine, low back pain, loss of energy. And so, yes, it can be related to that. Again, as I said, it's multifactorial in a lot of the situations. And so, being here in the office, we've got lots of different things that we do to try and tease out what the root is.
Do you prefer the chargeable or the non-rechargeable?
Well, the newest technology is the non-rechargeable battery, which has a lifespan that lasts anywhere from 10 to 15 years. The rechargeable has a lifespan of approximately 10 years. The rechargeable battery is about a third the size of the non-rechargeable. So it's really a preference for the patient as to whether you want to have the smallest implant possible that you're going to be recharging every perhaps 1 to 2 weeks, or if you really want a hands-free experience where you're not going to have to think about that battery for quite some time. We do the implant, the generator or battery that we implant, we put it in, I always refer to it as no man's land of the buttocks because it's below the waistline and it's above where you sit. And so it's in a kind of as least bothersome place as possible. Many of us are blessed with a little extra tissue back there. And so we can bury it deep enough that it's not something you can see. It's not a bump on the skin or anything like that. It is a metal device. And so if you push around back there after it's implanted, you will be able to feel where the device is implanted.
I had HDR treatments for prostate cancer and now need pads to control minor incontinence. Am I a candidate for the treatment?
Possibly. We talked about having some things that we do here in the office from a testing perspective to try and tease out whether that is stress incontinence or whether that is urge incontinence. And you have to remember, the urge incontinence source typically is the bladder. The stress incontinence source is typically the sphincter muscle, which is in the urethra. In that situation, it could be either. So we'd probably do a little further testing to try and figure that out.
If you've had a sling operation, will this still work?
Absolutely. The sling operation is something that we still commonly do, and that is done for stress incontinence. And so again, we're talking about urge incontinence with neuromodulation. And so it falls onto the other side of the incontinence equation. So having a history of a sling has nothing to do with this device.
Did you say Medicare covers therapy, and is there an age limit for treatment?
There is no age limit. I've implanted people well into their 90s, and Medicare typically along with a secondary will cover the testing, the office visits, and any implantation.
What is the recovery like after I have the implant?
You're going to have an incision that's about 3 inches long in the buttocks. That heals up quite quickly. You may be sore in the area for several days. You can be in the shower the following day. My restrictions are for the first 2 weeks of healing. I don't want you submerged underwater, so no swimming, no bathtub, no hot tub, and not a lot of strenuous activity that would put stress on that small incision, such as bending over and lifting. But I have people get back to work within 48 hours, and the recovery is minimal.
What kind of comments do you hear from your patients after this therapy? Is it a major or minor change for them?
It runs the spectrum from my life is completely changed for the better to I'm not quite certain how much improvement I've seen. And what I tell everyone is this device is highly programmable. It requires a lot of tweaks and adjustments in some patients. Sometimes we implant the device, we turn it on in the recovery room, and it is working very well immediately, and they immediately sense a difference in their bowel or bladder control. Other times we have to go through multiple programming changes to try and get this to a point where they're really seeing much benefit. So it's a little bit all over the spectrum.
What is the test process like, and is it different from the implant process?
Yes, it's a little simpler. The test is done here in the office setting. You lay down on your tummy on the exam table for about 15 minutes, and I inject a little Novocaine into the skin right over the tailbone. And as I said before, that's the most uncomfortable part of the procedure. It does sting a little bit as it numbs. And then I can take that fine little needle that I showed down by the ankle in an earlier slide, and I can go through that numb area, and I can move that needle around until we find the bladder nerve, and then we do the test stimulation. And that's where I ask you, what do you feel and where do you feel it? And the floor of the pelvis has kind of a spider web of nerves. And so we're very specific about where you feel the sensation. If you say, I feel that in the area of my rectum, that's a different nerve. Or if you say, I feel that more in the cheek of my buttock, that's a different nerve. Or if it's going down your leg, that's a different nerve. But if we get that down towards the floor of the pelvis or in the vaginal area or in the bladder or in men, a lot of times they will describe that they feel it kind of down behind the scrotum. That's an indication that we're exactly where we need to be.
What issues do you have going through airport security with this metal device?
Well, Medtronic hands out, you will have a little card that says exactly what your implant is. And if you show that to the TSA officers, typically that leads you straight to being hand wanded, and they know exactly where they're looking for the device to set off the wand. And it really is not a big issue.
I had bladder cancer due to radiation for prostate cancer in 2005. Prostate was removed. I cath every other day in effort to keep track or keep the neck of the bladder open. I had been taking all the meds that you had mentioned in your talk. I stopped because it wasn't working. I urinate all day and night wearing Depends 24/7. Am I a candidate for your procedure?
Possibly. Again, we'd have to do some testing to figure out if that is more related to weakness or damage to the sphincter muscle, which would ultimately be stress incontinence, or whether that is related to overactivity coming from the bladder, which is right up the alley for nerve stimulation.
And I have one more question here that says, are you able to control the Interstim systems once having the implant? If so, what kind of device?
Once you have your implant, you have what we call the programmer, and that can turn the device on and off. We recommend that it be turned off when it goes through security at the airport. It also is responsible for making all the adjustments and program changes. And as I said, sometimes there are very few changes. Sometimes it requires multiple changes. But once those changes are made, this device goes away in a drawer at the house and you forget about it. It's not something that has to travel around with you when you're in town. We do suggest, at least when getting started, that it travels with you if you're going to make a trip out of town, just in case an adjustment needs to be made. But these adjustments can be very simply made. We make sure that the patient is well educated and knows how to make these adjustments. Then we have a support line for Medtronic, which is helpful over the phone. And then we have Vilma and her counterpart, Annie, who both work for Medtronic and work with our patients on a daily basis.
I think that sums it up. And I'm going to go ahead and send out a poll so that everybody can go ahead and answer that for us. That would be very helpful. If you have any further questions, now's the time to reach out, but we are so glad to have had you this evening. Dr. Walsh and Kara, you have been instrumental in giving us all kinds of great information, and we hope that we can help all of you in the best way possible for you or your loved ones. And we look forward to hearing from you in the future.